So hello, everyone. Again, thank you for your patience and a very, very warm welcome to you wherever you're joining us from today for a very important discussion indeed and a webinar titled Racism in Healthcare, Why Should You Care? My name is Shilpa Venkatachalam and I'm honored to be your facilitator for this evening's discussion. I am also the Associate Director of Patient-Centered Research at the Global Healthy Living Foundation and also the co-principal investigator on Arthritis Power, which is our research registry and tracking app for people living with different types of rheumatic and musculoskeletal diseases. Arthritis Power currently has more than 30,000 members. Our mission at the Global Healthy Living Foundation is to improve the lives of people living with chronic disease through better access to care, education, support, advocacy, and patient-centered research. And in line with that, we have been conducting webinars like this one for over 2 years now as a way of bringing research to you and facilitating dialogue on important topics in healthcare between researchers, clinicians, advocates, and patients. So again, very warm welcome to you all. I know we're eager to dive right in, so I'll take a few more brief moments, just 5 more minutes, to quickly frame our discussion for today and then go through some housekeeping rules, and introduce to you our very distinguished panelists. 2020 and now 2021. It's been a year of reckoning for so many reasons around the world and right here in America. Communities across the world and here in the US have been ravaged by the COVID-19 pandemic. And while the pandemic here at home has exposed the stark reality of racism and its effects on the health and healthcare of Black and Brown people and on marginalized communities, it certainly did not create it. From the beginnings of slavery in 1619, perhaps even before then, through the violence of the Tuskegee syphilis experiment and to our current times today, where we were collectively shocked by the brutal murders of George Floyd and Ahmaud Arbery, only to learn of so many more, we cannot deny any longer that racism is deeply embedded in all our institutions, including legal, political, educational, housing, employment, and of course, healthcare. So how in fact does it manifest actually in health and healthcare? What does racism in healthcare actually look like, and why should we care? To discuss these very important topics, I'm delighted to be joined by an expert panel today. Our first speaker for this evening, Dr. Jillian Rose, is the Assistant Vice President for Community Engagement, Diversity, and Research at the Hospital for Special Surgery. Dr. Rose also provides ongoing leadership and support for the hospital's collection of gender identity, sexual orientation, race, ethnicity, and preferred language data. Next, I'd like to introduce Dr. Irene Blanco, who is a professor in the Department of Medicine and the Associate Dean for Diversity Enhancement at the Albert Einstein College of Medicine. Her research interests focus on addressing health disparities and the social determinants of health in medicine and in rheumatology specifically. And last, but certainly not the least, we have Dr. Ashira Blazer, Assistant Professor in the New York University School of Medicine, Division of Rheumatology. Her interests are in studying the biologic and genetic determinants of systemic lupus severity in patients of African ancestry. Through her research, Dr. Blazer aims to provide personalized treatment options to the most vulnerable of patients. It is truly an honor to be joined by such distinguished panelists, and very warm welcome to them. Lastly, and very, very quickly, I'll just go through a few housekeeping rules so we can keep the discussion moving. Please note that all audience members will be placed on mute. This is mainly to help us ensure a good quality recording for the webinar, so people who are not able to join us and attend live can access it at a later point. So the webinar will be posted on our website at www.creakyjoints.org. This webinar is, of course, for all of us, and we encourage discussions and questions. And even though audience members are on mute, please, we encourage you to send us your questions via the chat box or the question box, which you should see on your screen. I think it appears as a very small little gray box in the corner. So please feel free by all means to send us your questions at any time. Your questions, in fact, make the discussion all the more enriching. Panelists will present for about 10 minutes each, and then we will have a Q&A session, a question and answer session. So once again, please send us your questions. We'll try to get to as many questions as we can, but given that we have 1 hour, if we don't get to your questions, we apologize in advance. So with that, I'm going to turn it over now to Dr. Rose, our first speaker for this evening. Dr. Rose?
Thank you so much, Shobha, and thank you for having us tonight to talk about this very important topic. Thank you all participants out there for joining us. We hope to have a robust discussion and continue this discussion beyond this webinar tonight. But I will help to frame this conversation by starting to talk about and to think about what's structural racism, right? We just heard Shobha's introduction and description around racism and discrimination and the impact that it has had on our social and political and economic structures in society. And this is not new. This is not just because of COVID-19 or the Black Lives Movement, but we know our history in America have been bookmarked by slavery, by the civil rights movement, by Jim Crow. We know that we have a history of Tuskegee and experimentation on people of color. We know that in this country, we also have a history in healthcare where people are unfairly treated and medications and treatment are withheld from people who identify in categories of people of color. We also know that there are issues around the burning down of Black Wall Street in terms of financial and economic well-being of communities of color. We know that we face issues around mass incarceration that we continue to face in our country. We know that we have injustices around police brutality and over-policing of different neighborhoods. These ills all add to the stressors that is systemic racism. And so it's important for us to have the conversation within the context of what bookends our society, whether it's socially, financially, and even in the context of healthcare. So structural racism, by definition, is the ways that policies and practices of organization or systems advantages some populations while disadvantaging others, creating different outcomes for different racial groups. Right? And we only have to look to COVID-19 within the last year to know that different populations are disproportionately affected by the pandemic. And I'll talk about that a little later. But since the Black Lives Movement and the killing and murder of George Floyd and others before him and after him, there has been a momentum to have these conversations within the context of our society and within the walls of healthcare. It's important for us to understand that as healthcare institutions where we work and go to get care, what's happening within the context of our structure? Is it just driven by individual racism? Are there just some bad people who are discriminatory to other groups of people? Or are there systems at play that we need to critically look at that drives bias, inequities, microaggression, and ultimately systemic racism? I'll take the next slide. So when we look at hospitals and healthcare structures, we know that hospitals in underprivileged areas continue to be underfunded, understaffed, right? And there's limited care for the communities that they serve. Often these hospitals are in places where the population is larger than they can really care for. We know that segregation by insurance, such as a person with Medicaid have longer wait time for surgery, for seeking routine care. We know that when you go to hospitals where there's private care and Medicaid patient, oftentimes the area that serve our patients who have Medicaid don't look as nice and they're not as well staffed. And so as we walk through the halls and the different communities where our healthcare facilities are, we notice stark differences, right, in care and in appearances, in wait time, and especially in outcomes, which we'll talk about health disparities later. We know that there are also historic inequalities, such as in housing, right? And I talked about redlining and in the last couple of years, subpar lending, where they are loans that are bad loans or high interest loans that are pumped into communities of color. So they're borrowing more money at higher rates and oftentimes are subject to foreclosure and unequal housing stability, right? We also know that there's unequal treatment in the context of employment. There's so much data out there. You just take a Google to see studies about name recognition, you know, whether looking at the same resume that comes into a company and Carlos Rodriguez does not get the call back, but Charles White may get the call back. And the only thing that's different about Carlos Rodriguez and Charles White is their name and not even the resume. So we know that there's hiring practice that's biased towards different populations. And some of that bias is very intentional and ingrained within the context of our institution. And some of it is unintentional and need to be dug up and shown a light on. Next slide, Shilpa. So as we talk about this concept of COVID-19, right, we know that people who identify as minority groups or people of color have been hardest hit by the pandemic. And we know that there are a variety of reasons for this. And some people say, well, most people of color are on the front lines. You know, they are our bus drivers and our UPS delivery people. Other people might say, well, there's discrimination in healthcare in general. Others might also say there's education and income access in terms of how people protect themselves, right? But we all know that all of these factors have fringes of systemic racism that drives the outcome of COVID-19 and its impact on the minority communities. Within the context of talking about minorities, we know that the COVID-19 has hardest hit the Black community. And this graph really accounts for the number of people of color who experience greater mortality than even their other minority counterparts. So Black individuals accounted for 13% of the US population in 2019 and 22% of COVID-19 related deaths, right? So Black people are dying from COVID-19 at a 2.4 times higher rate than their white counterparts. Right? So what makes the Black community more at risk for COVID-19, even within the context of all other minority groups, right? So we know those groups have higher rates of pre-existing healthcare conditions. They're overrepresented on the front line, as I mentioned, and they have unequal access to healthcare, health insurance, and coverage. And they more likely live in hyper-segregated neighborhoods where there are not a lot of resources, or their resources, however, it's not enough to accommodate the need of the population. So all of these factors are at play within the context of this pandemic that we see within a pandemic. Shilpa, I'll take the next slide. So I want to talk about, as I wrap up, what does health equity look like, right? So we know that on your left, on my left side, probably your right side, depending on how you're sitting in this picture, we see that in the cartoon below, the first image shows inequality. One person has the access to the apples falling from the tree and one person doesn't, right? Clearly, you know, unequal, and that's inequality. The second picture represents equality, which both people are given ladders of equal height to the trees, right? To the tree, and it leans on the left, making the apples more accessible for one person, but not the other. So, you know, equality sometimes, you know, you have access, but you don't have exactly what you need, right? The third picture represents equity. The person on the right side of the tree is given a taller ladder to access the apples, where the person on the left hand has a shorter ladder that allows them to access the apples that are hanging right over their heads. And finally, there's justice, right? In this, we see that the tree is straightened up, right? Thus removing the barrier for the person on the right and he's no longer needs a taller ladder to access the apple because we've straightened up or we've evened the playing field. Right. And so when we look at our society, when we talk about equality, equity, and justice, justice takes into account outside the legal context of criminality or punishment. Justice really involves removing the barriers that prevent equality and in many cases equity. Right. And so it's important for us in healthcare to strive for this concept, not only of equity, but this concept of justice and fair treatment, giving people what they need to succeed within the context of our system. Next slide. So I want to wrap up by sharing some of the things before I hand it over to my colleague Irene about, what can we do? What can we do? What are organizations doing? And it's important for us to provide training to our staff and our teams to enhance the understanding and awareness of structural racism. Many people like to say, well, I don't see that, or I don't see color. And we can have a whole conversation about color blindness and how it perpetuates structural racism, right? And so we can answer some questions about that later. But it's important for people to really understand and really pull back the onion and the layers, right, on our system to take a critical look at the mechanisms that are driving inequality and inequities. We want to create partnership with multicultural communities because oftentimes perpetuation of structural racism, it's because we don't talk with each other and we don't know each other. So we cannot give people what they need if we don't understand their needs. And we want to seek to attract diverse opinions and diversity in the context of our decision making and at the table. At the highest level of our healthcare institutions, we need to hear the voices of our populations, right? And we want to collect patient race, ethnicity, language, sexual orientation, gender identity data. So when we're looking at quality, we're not just saying, oh, this segment of our population is doing great, but we want to look at all segments of our population to understand how well they're doing within the context of care. One of my colleagues said these data sets are like smoke detectors in our homes. You'll never hear the alarm if the smoke detectors are turned off. So if you don't have the cues to tell you that something is going wrong or different for one population versus the next, and you're not measuring that, you'll never see structural racism. So with that, I'll turn it over to Irene.
Great, thank you so much. So, as Dr. Rose just so wonderfully presented, no man is an island, no woman is an island, and everybody lives within their own context. And so when we think about all of the issues that affect the individual patient, we think about them in terms of what we call the determinants of health. And so as presented by Dr. Rose, we see that you have the individual in the green circle below, and that's their individual factors and their risk factors for disease, their age, their sex, any particular genetic factor, etc. As we move out on this semicircle, you'll see then there are individual choices that a patient makes, right? Whether or not they drink alcohol, whether or not they smoke, whether or not they exercise, etc. But we know that those things don't necessarily exist within a vacuum. And a lot of times society and community networks will actually influence how a patient decides to make individual lifestyle choices. So for example, if a person is exposed to a lot of smokers and grew up with their parents smoking in the home, they're actually much more likely to be a smoker themselves. If we see, for example, that a patient lives in a neighborhood where, for example, they don't have necessarily access to a lot of supermarkets, etc., they may make the choice to eat foods that are not necessarily the most healthy because those are the resources that are available to them. So as we grow out on this circle, we see that, for example, agriculture, education, work, living environment, employment, housing, etc., and greater socioeconomic, cultural, and environmental factors are all going to influence and trickle down to an individual person's risk factors and how their individual illnesses will not only manifest, but how their severity and their subsequent sequela as they move forward. Next slide, please, Shilpa. So we're going to drill down now on a couple of rheumatic diseases specifically, and I'm going to talk mostly about lupus and rheumatoid arthritis because those are actually the diseases where we have some of the more robust data. And we're not going to do too much of a deep dive because that would take the entire hour. But just to say that lupus in and of itself is much more prevalent in communities of color. So we see baseline that at least in the United States, Black, African American, Hispanic, Native American, and Asian populations tend to have much greater disease activity when presenting with lupus. And they also tend to have a lot worse disease. So these patients tend to be refractory to medications. So these are the patients that no matter what medicines you give them, they tend to progress and accumulate organ damage as their disease gets, as they're living with their disease. But in addition, they tend to also have higher risks for mortality. So they're higher rates of death in terms of lupus. So, you know, as if we think about Dr. Rose's presentation, go back, please. If we think about Dr. Rose's presentation, we think about the determinants of health, all of these things play together into how challenging a person's life is going to be with their lupus disease activity. And so SES stands for socioeconomic status. And so we know actually from a large lupus cohort called the Lumina cohort that showed that disease activity was intricately tied not only with race and ethnicity, so Black and brown patients do worse, but also patients that are living in poverty, patients that have low health insurance or lack of health insurance, and those that have less formal education tend to have much higher disease activity and therefore a lot more organ damage because of their lupus. Next slide, Shilpa. And how does that play out? So in general, Black and brown patients tend to have higher risk for mortality. And so they're much more likely to unfortunately die from their lupus. But when you actually look at these populations, you actually can't take out the risk factor of poverty in these groups. And poverty on top of it makes it much more likely to die from lupus. And it's been shown in multiple different cohorts. In the lupus cohort, in the Lumina cohort, the Carolina cohort, and in the Hopkins cohort, oftentimes poverty really is what explained the differences that we see in race. And so as Dr. Rose presented in structural racism, where you have a group that was disadvantaged to the point of being driven into poverty and denied generational wealth, when you're poor and you have a disease that's going to affect you dramatically, it's going to just amplify your risk of dying from said disease. Next slide. And so we see something very similar in rheumatoid arthritis patients as well, that patients with RA, we know that, for example, education, race, socioeconomic status do have a large impact on their disease activity. So patients in a set of clinics in UCSF, we saw that white patients tend to have lower disease activity and tend to have much higher function than non-white patients. And patients that spoke English and those that were born in the US also tended to have lower disease activity scores. Now, this could be multifactorial. Could it be that lower English proficiency patients, so patients that don't speak English, didn't necessarily understand their medication regimens as well? Possibly. Could it be that poor patients and patients with with poor health insurance weren't necessarily offered our very costly rheumatoid arthritis medications? Potentially. But we know that, again, thinking of the terms in the determinants of health, all of these things conflate together to poor outcomes. And so for the individual patient, it's probably a different set of factors than for the next patient. But overall, we know that access, insurance, education, literacy, etc., are all going to come together for poor health outcomes. And so I'll now turn it over to Dr. Blazer.
And thank you, Dr. Blanco and Dr. Rose. So, I think that all of this sort of falls together under this structural racism, social determinants of health. And I think we talk about how race is this social construct, but I think it's very important to talk about how race as a social construct has been intertwined with biology, and how that influences the ways that Black and Brown people receive healthcare and experience the healthcare system in our country. So, just tying it together, it's easy to say when seeing stats like Dr. Blanco presented, is there a different biology? Perhaps, there's some biology that's affecting these diseases that goes along with these racial divisions, and this is why we're seeing these differences. But I want to go back to the history of this country and explain that race, as Ta-Nehisi Coates says, race is the son of racism and not the father. And what I mean by that is that Blackness was really made in this country. The immigrants who came to this country built America on this foundation of justice for all and freedom. And yet this was juxtaposed with this permanent slave class and Native genocide. And so this race theory became rooted in biology in order to justify the ways in which we practice social politically in this country. So the race is essentially a caste system. And the theory of race is that racial groups are biologically discrete, as evidenced by physical characteristics. And we'll get into how we define those physical characteristics and how that still influences medicine today. Races are naturally unequal and therefore must be ranked hierarchically. So it's also important to understand that our concept of race suggests a hierarchy from its inception. Each race has distinctive cultural behaviors that's linked to their biology. So even this question of biology as linked to race is rooted in this history of racism. And differences among the races are profound and unalterable. So, and I'll take the next slide, Shilpa. So where did this come from, and how does it still play out in medicine today? So, in 1851, as we were coming to a fever pitch with our struggle with slavery in this country, there was a medical doctor and scientist named Cartwright, and you can actually still look up this document. But he was charged by the Medical Association, by the Medical Association of Louisiana, to provide scientific support for this racial caste system. And so he wrote this definitive document in the Medical and Surgical Journal describing the biological differences between the Negro and white. And some of the stereotypes that he puts in here are actually found throughout medicine and still found in some of our thought processes today. So, Dr. Cartwright was the first one to say that Black skin is thicker and dry and harsh to the touch. And I think that we've seen, there was a publication in PNAS that came out showing that many medical residents felt that Black skin was thicker indeed, that Black people were unable to feel pain, that there was a dullness to their sensation related to thinner blood vessels and inability to carry oxygen throughout the system. And we know that the justification for doing surgical interventions, hysterectomies, on Black women without treatment, without pain treatment, was that there was this idea that Black people couldn't feel pain. And even today, we see that Black and brown people are less likely to be treated for their pain and are thought to have higher pain thresholds. So, you know, it was an uncomfortable exercise to go through this document, but I think one of the really surprising things is that this is something, it's almost like we've been playing a game of telephone with Dr. Cartwright and all of his contemporaries, because a lot of these views are maintained in medicine. And so, you know, we talk about Tuskegee, we talk about Henrietta Lacks, we talk about all of these instances where there were clear, where there was clear evidence of mistreatment of Black and brown people in medicine. But I think what we really have to understand is that the meshing of race with biology was really the original sin of medical science, because the justification, the legitimacy of racism, the defining of people of different racial groups as less than human came from this ideology. And that is what allowed for things like Henrietta Lacks. That is what allowed for things like Tuskegee to happen. Next slide, please, Chelsea. And so I think it's really important that we understand that when we're measuring differences due to race in medicine, what we are really measuring is the effect of racism. All of those social determinants of health that go along with being in a group of people who are historically and really currently marginalized have health effects. And those health effects are what play out in our clinics every day. So, you know, I want you to view the stats that Dr. Blanco gave us with the mind that these differences are due to differences in treatment and differences in the ways in which certain people live our lives. And even when we think about something like genetics, we know that genes are a substrate that are acted upon by a certain environment. And you can almost think of structural racism as a different environment, right? So people in different races don't have a shared social political environment, and therefore the biology behaves differently in a context that is dishealthful. Next slide, please. Sure. Okay. And so I think that this is, so bringing it back to lupus. This is a slide, this is a figure that's shown very, very often, but I want to discuss it again in the context of structural racism and how it might be affecting these outcomes. So this is a study that was published in A&R in 2018, looking at major causes of death of American women. And this was divided by certain decades. So women years 15 to 24, 25 to 34, 35 to 44. And the authors looked at, well, first they excluded accidental deaths, but then they looked at all women, Black women and Hispanic women. And they found that lupus was an underappreciated cause of death. And in fact, for all women, it was the number 7 cause of death in the youngest age group. However, when you looked at Hispanic women and African American women, the authors found that it remained a top 10 cause of death into the 4th decade of life. And so, you know, we think about this, and again, we think about potentially biology, but what we have to really understand is, and I think where research needs to go, is what factors that are exacerbated by being in a marginalized group impact lupus biology. What's the difference between someone who got lupus and her symptoms, his or her symptoms were taken seriously, and they got a diagnosis within 3 months and got on treatment, versus someone who had to wait 3 years for their diagnosis? I mean, we all know we wouldn't expect someone who developed breast cancer and had a diagnosis made 3 years later to do as well as somebody who got detected early, right? And yet we don't think about how this difference may impact lupus pathogenesis. What is the effect of taking medication and then losing your insurance and then not having medication and then trying to resume. What does that disruption in care do to lupus and its disease course? You know, what is the biological effect of chronic stress due to structural racism on the immune dysregulation of lupus, right? I think these are the kinds of questions that we need to ask, because as we know, race is not a great proxy for biology. It's not a great proxy for genetics. And so if we are seeing things, outcomes that fall very sharply along racial lines, we know that this cannot be due to genetics, and this cannot be due to biology. What falls along racial lines is oppression. And so I think that when we're thinking about these things scientifically, we really need to weave that into the narrative and understand what racism does to lupus biology, how racism becomes disease. Next slide, please, Shilpa. And so how do we think about this? How do we make some solutions? Where are the low-hanging fruit? How do we reach the higher hanging fruit? And so I think the first thing we do is we have to recognize, name, and understand these attitudes and actions. So we have to recognize racism. We have to understand the structures. We have to understand, as much as we want to look at, you know, pathways and genes and medications, we have to understand how all of the overlaying social and structural ills affect our patients. And we have to be able to find that phenotype. The next thing we have to do is educate. And when we say educate, we often think educating patients or educating medical students, but really we need to educate. There needs to be 360 education, right? You know, this is something that needs dismantling, okay? Structural racism was built on purpose, right? And the way that we think about it going away is just, over time, it'll get better, right? That's like building a skyscraper in the middle of downtown and then just waiting for erosion to break it down. You know, that doesn't happen, right? And so I think that it's really important for us to educate everyone who has their hands in this problem. Leadership in medicine, practicing physicians, medical students, pharmacists. And I think also this is where patients have a viewpoint that we all need. So I think that this education needs to be bi-directional. Having conversations can be a great first step, but it's not the last step. So I think that it's really important that we're having this conversation. But I think that actionable items need to be implemented in order to really affect change. And then ultimately, we have to increase representation. So, you know, I think a big legacy of the segregation that we see in this country is that it's really hyper evident in the most elite of places, right? And, you know, I think medicine is this sort of pristine place that we give this privilege, and many, many medical doctors are not reflective of the patient population that has to be seen. And I think that creates a power dynamic that's problematic, that creates an unfamiliarity that's problematic. And I think that representation is going to be really important so that we can all communicate with each other and live in a world where everyone is the same degree human. Next slide, please, Shilpa. Okay, and so I think we are ready for our Q&A.
That's right. Thank you very much to the three of you. You know, I feel like we did a bit of injustice by giving you 10 minutes to talk about something so complex and so vast in terrain, but you all really did provide some fantastic information. So thank you once again. We have a number of questions that are coming through. And so I'll try to combine questions here so we can get through as many as possible in the next 15 minutes. So why don't I come back to you, Dr. Blazer, actually, and then I'll work my way backwards through Dr. Rose and then Dr. Blanco. So I think, we have 2 or 3 questions and asking pretty much the same thing. You said, we're talking about race here. We often hear race doesn't exist. Of course, racism does. And you said race is not biology. So can you explain or talk a little bit about things like genetic predisposition, genetic differences? Is it right for us to talk about those things? We've heard often with sickle cell disease, for example, that Black people are genetically predisposed to it. So if race doesn't exist, how then are we saying something like that? Could you talk a little bit about that?
Yeah, and so I think that when we talk about genetics, we need to disentangle it from race. When we say someone is genetically predisposed, what we mean is there is a gene that increases the risk of some sort of disease, maybe sickle cell, and that gene is passed down from common ancestors, right? So it's not that anyone who's Black could get sickle cell disease. It's that someone who is generally from this area of the world, who has a common ancestor who carried that gene, could then carry that gene, right? So in the same way that we would never say that all white people have thicker mucus because they have cystic fibrosis, we would say some people of European ancestry carry the genes that can lead to cystic fibrosis. We can't just say that Black people are genetically predisposed to certain illnesses, right? So I think it needs to be couched in ancestry and how genes follow certain genetic trees rather than as a blanket statement about race, if that makes sense.
That was great. Thank you. Very helpful. And important to know because we often confuse and use those terms interchangeably. Dr. Rose, a question for you. We're bringing this back now to COVID as well. Of course, we're in the middle of the pandemic, and we are also in the midst of the vaccine rollout. So, we often hear this term vaccine hesitancy. People are hesitant to get the vaccine. People are skeptical of the vaccine. But there is another conversation that comes into the picture when we're talking about people of color, where we say people of color are reluctant to get it, but don't sort of display vaccine hesitancy. Could you talk a little bit about that? Why is it that when we talk of people of color, we're talking about something else other than, say, just plain vaccine hesitancy?
Right. And so sometimes we're looking at the comparison between people who are anti-vaxxers, right? And that generally means that they're against any type of vaccinating, right? Or vaccination per se. When we talk about people of color being hesitant, right? We talked about this bookmark of our history and the marginalization, the experimentation that was done on people of color throughout this country. It is 1972 was the year when the Tuskegee experiment stopped. And many of us here on this call can remember 1972. It is 1997 when President Bill Clinton issued an apology for what occurred with these families and these Black men in the Tuskegee study. So people have a very recent history and a memory of being experimented on, right? People have a very recent memory of going into hospitals and not being given pain medication because they were considered to not feel pain in the same way as other population. And we have a very recent memory that women of color right, who have master's and doctorate degrees, they have far worse mortality rates for their babies than their white counterparts who are less educated and less financially stable. So when we look at our society, we're still talking about disparities that impacts communities of color that goes beyond this concept of biology, that goes beyond this concept of poverty and financial issues and neighborhood issues and insurance card. So we know that Black women account for about 13%, right, of people who get breast cancer, but yet 40% of them are more likely to die than their white counterparts. So when we look at COVID-19 and something new coming on the market, healthy skepticism is based in the current reality and the current disparities that we continue to face within the context of our community that disproportionately affect people of color, especially Black people.
Great, thank you. And, you know, I know we've been also talking a lot about a focus on lupus and rheumatoid arthritis and rheumatic conditions. But, you know, also just so for our audience to know, these are concepts that can be applied broadly, and in fact must be applied broadly to healthcare and health different diseases and in general. Dr. Blanco, the next question is for you, and there's so many good questions here, so I'm having a bit of a time juggling these questions, really important ones. But Dr. Blanco, can you talk a little bit about the difference between race and ethnicity? You know, we all are either researchers or clinicians or patients. We all either create surveys or often sometimes take them, and we always sort of have these questions that ask about race and ethnicity. So a little bit about that, and which one is more important, if any, in healthcare?
You know, I mean, I think it just baseline, race and ethnicity are pretty artificial constructs, right? It's sort of how people have been divided, sometimes how people divide themselves and how people have been divided by other people. And it's a way of categorizing people, race being based on physical features, how much melanin you have in your skin, the slant of your eyes, the curl of your hair, etc. Where ethnicity is more rooted in the place where you live, where you're from, where your family is from, etc. So you can think of, if you want to think of, for example, the Black diaspora, the African diaspora. There are African Americans, but then there's Afro-Cubans, there's Afro-Mexicans. And so while all of those people may potentially consider themselves to be Black, you know, they also, based on their ideas of race or ideas of race that have been put upon them, there's also the ethnicity of I'm Cuban, I'm Mexican, I'm American, I'm Italian, I'm Irish, etc. So that would be sort of the ethnicity. And then you, of course, then get micro ethnicities within an individual country or region based on different ethnic groups that may exist within a certain population. You know, in terms of healthcare, it's really hard to say which one's more important, because they're tying together. So you can think of, so for example, I think by sheer coincidence, Dr. Blazer, Dr. Rose, and myself were all in New York, where we have a very large Afro-Caribbean community. And there are certain subsegments of that community that speak English and that don't speak English. And for example, in the Haitian community that speaks predominantly either Creole or French, or in the Dominican or Puerto Rican communities that may speak predominantly Spanish, language then is an additional barrier on top of race, on top of immigration status, and this then ties into the determinants of health, right? So it's that multiplication and amplification of different traits of, if you are Puerto Rican, you're an American citizen, so you automatically get access to Medicaid and Medicare. If you're now Dominican, you potentially might be undocumented and you may not necessarily speak English. So whatever racism you may or may not be facing, depending on the color of your skin, then gets tied into your documentation status to therefore decide what insurances you can get, and baseline language in how well you can communicate with the entire system and your providers. So it's hard to extricate the two and say, you know, which one is more important in terms of healthcare. And I just wanted to add something to, you know, what Jillian was saying. And I think maybe because I was just on the COVID floors this past week, you know, patients encounter racism actively in clinical encounters. So while, and I feel like people feel like Tuskegee was a long time ago, it was 40 years ago, that's not that long. But the spirit of what led to Tuskegee is still walking down the hallway. And that trust is not necessarily there between patient and provider. And so the trust to take the vaccine is also the trust that's maybe not there to take medicine, to take certain, you know, treatments, to take, because trust is earned, right? Trust is not automatically given. And there's still too many providers that don't engender that trust with their patients and don't partner with the communities that they treat. They're not of the communities that they treat. They don't live within the communities that they treat. Hell, they don't even go to the bodega on the corner, right? They don't even leave their clinics to even understand just 2 feet outside of their hospital setting, just who is the population that they're treating. So, you know, a healthy skepticism happens because, frankly, not enough providers have really done the work to gain the trust and the partnership on you know, the part of their patients.
Yep, that's you know, the sort of the grim reality that hits us all. And you kind of led me to my next question, and I'll come back to Dr. Blaze. And of course, anyone, please, all three of you, feel free to jump in at any point. So I'm just thinking of how best to frame this. You know, there's, Dr. Blazer, you talked a little bit about Cartwright. Dr. Blanco and Dr. Rose talked about the past and how the past is never the past, right? It still sort of shapes us and defines us, I suppose. And so, you know, there are all these shocking ideas. You touched upon surgery being done on Black people to test really their threshold, really cruel, horrible things in the past to test their thresholds of pain, etc. We've heard things about Black ideas, outrageous ideas, Black people having thicker skin, less sensitive nerve endings, so that pain is felt less. And, you know, when we think about these ideas, we are comfortably enraged because we think these are ideas of the past. And this doesn't happen today. So my question to you is, how do these beliefs carry on to impact medicine as it's practiced today? And Dr. Blanco touched upon this, but just to continue the conversation, could we have you all talk about that a little bit, please? Dr. Blazer?
Yeah. So I always say that this is a living history. This is not something that is in the past. This is something that has been baked into our practice of medicine. So I also give the example of the spirometer. So the spirometer was actually invented by Samuel Cartwright, and his hypothesis was that Black people, or Negroes as he called them, had lower lung capacity and therefore were unable to oxygenate parts of their body as well as whites. And so he invented this machine to be able to detect just the mechanics of the lungs and oxygen in the body. And so this lung function test was given with a spirometer, and he found, of course, in slaves who were malnourished and who were mistreated and overworked, that their lung capacity was lower. we actually still use this parameter for pulmonary function tests. And today, if I order spirometry on a Black patient, it's corrected for their race with the assumption that their lung capacity is lower. Now, imagine that someone comes in and they have early lung disease, early pulmonary fibrosis, early asthma even. We know that this affects the Black community more. And of course, it's best to treat that at the inception, because we know that people do better when they get early detection. And this test is less sensitive for Black people. Now the provider doesn't even have to be racist. The test is going to delay diagnosis because the barrier, the bar for abnormal is higher for a Black person, right? So, you know, while that is a crazy example that's just been carried on and nobody decided to, you know, actually do a real study here, I think it's a metaphor for all of the other aspects of history that we carry with us. You know, it's like a closet that we just never cleaned out, and we, you know, got a storage unit, and now we just carry this baggage with us, right? A lot of the ways that we view people of various races, a lot of the ways that we view the implications of races, a lot of the ways that we study the medicine. I mean, you know, just as Dr. Blanco said, that these ideas are still walking down the halls with our physicians, you know, the people who ask questions in medical research are the ones who find answers and the ones who write the papers, and the papers become the knowledge that fills our textbooks, and those textbooks are taught to medical students, and that impacts how we treat our patients, right? Who's asking the question? Because as much as we don't have inclusion for healthcare providers, we really don't have inclusion for physician scientists, right? If we're asking racist questions, if we're asking questions with a premise that is discriminatory in the first place, we're going to get racist answers. And that's what's going to populate our textbooks and our patient papers and how we practice medicine. And so, you know, I think that there are lots of ways that this just gets invented and recycled and repurposed, and it affects the experiences that our patients have.
Great, thank you. And I see that we're sort of coming to the top of the hour, but I'm going to take five extra minutes, if that's okay. And thank you also to the audience, because this is just too important a conversation to wrap it up. And we will wrap up, but I think what we can do in the last few minutes is, if you can talk 1 minute each. I know, again, sorry to put this time constraint on you, but we hear this over and over again. I'm not racist. I didn't say anything that was racist. So if I'm not a person of color, right, does that mean that I'm racist? Does systemic racism mean that everyone who is not a person of color is racist? So, we can start the opposite direction, the sense that with Dr. Blanco, Dr. Rose, and for Dr. Julian Rose, your name, we apologize because your name has appeared as Dr. Irene Blanco throughout this presentation, but we will correct that, and then I'll go on to Dr. Blazer. So Dr. Blanco, do you want to start, maybe?
Sure. I mean, I would argue that because of what I call the toxic stew that we're all raised in, the media images that we see, the propaganda that we've been fed, the structures that we've been raised in, the history books that, raised us through elementary school, where it's viewed through very Western lenses, that all of us to a certain extent are racist. And have a lot of internalized just biases and prejudices, etc. And it's a very active process to be anti-racist, right? To really break down all of those systems. Dr. Blazer, I really love the analogy that you said, right? You can't build a skyscraper in the middle of Midtown, right? In the middle of a city, and then just kind of hope that the weather knocks it down, right? When it's reinforced with steel and concrete and all of these bolts and nuts, etc. You know, and those are the structures in which we live. And so even if you try to consciously live a good life, if you don't really consciously try to knock down these systems of oppression and your role in them, no matter where you are in sort of the machine, potentially you may be perpetuating racist actions, thoughts, and behaviors, while not necessarily wanting to.
Right. Right. And I think that's a good segue into looking at issues and structures around implicit or unconscious bias or racism versus very explicit racism. And again, I like to say that each of us come to care, and doctors, nurses, healthcare professionals, social workers, and even our patients, none of us come in and say, we want to serve our care with a side of racism. But it's important for us to acknowledge that there are stereotypes that we've grown up with, and there are other experiences, right, and impressions and media that we're bombarded with every day that shapes our unconscious thinking and our unconscious mind. You know, one of the things that I want to point out is the psychological impact of discrimination, and that is a cumulative impact that causes negative health outcomes. For example, we know that before 9/11, 6 months before 9/11, women who identified as Arab descent, you know, had babies with regular birth weight. 6 months after 9/11, because of all the stress of that event and the marginalization of the Arab community, women in California in one study were given birth more frequently to babies with low birth weight, right? And so the stereotypes and the images and the actions that are happening in society, whether it's your lived experience or it's vicarious because of all of what you're taking in, it really confounds the stressors that you live with and that you carry that can then translate into negative health outcomes. So it's important for us to understand the psychosocial or psychological impact of discrimination. Oftentimes as clinicians, we say we don't see color, or I'm not racist, or I'm not prejudiced. And when we go in with that stance, it's a conversation stopper. It doesn't allow us to look for indicators or ask appropriate questions that help us to untangle the system. For example, women of color are often discriminated against in the highest level of the SES bracket. So sometimes you see a person come in, they drive a nice car, they have a PhD, they, you know, are making a lot of money, they can purchase healthcare and don't even need insurance. And there are assumptions that are made about them in terms of their ability to take in healthcare, follow instructions. And so oftentimes they're neglected in terms of the discrimination they face, the fear that they have, the mistrust that they've developed based on discriminatory experiences. So this is not just about me, myself, individually being racist. This is about a system that we grew up in, a system of experiences and continued systems of structural racism that puts us in a place where we cannot not think about actions that might be racist. We can't not think about actions that are driven by system that we continue to perpetuate intentionally or unintentionally.
Yeah, and I echo everything that my colleagues have said. And I just want to, you know, I think one of the barriers to really thinking about this is that people think that racism is some like mean thing that we do to each other, right? Like, or if you have racist views or racist thoughts, or you've done something that could be considered racist and you're just this evil person, you know? And I think it's important for us to understand that we are all, as Dr. Blanco said, steeped in the same culture, right? So that means that we all carry these, we've been indoctrinated with this understanding of the racial caste system and just how society is, right? So, you know, even when we think about imposter syndrome, I think Black and brown people talk about imposter syndrome all the time. What is that? That's a Klansman in your head, right? That is some viewpoint that you have that says, because I'm Black, because I'm brown, because I'm a part of this group, I'm unable to reach this level of excellence, right? That's you being steeped in that same culture, right? So, you know, I think that it's important for us to understand that this is cultural for us, and it's something that we really have to think about intentionally in order to do something about. And I think the last thing I'll say is that when people say, I don't see color, the experience of racism is the experience of not being acknowledged as fully human, right? It's the experience of the default being centered on whiteness and your reality being denied, right? And so I think that the idea of not seeing color means that it's a obligate denial of someone else's experience, right? Like if I experience the world differently because I'm African American and I experience that discrimination, you say I don't see color, you are basically negating what it is that I carry with me day to day. And so I think part of dismantling racism is really being able to relate to each other, to hear each other, to experience each other's cultures, and then say all of this is on the same playing field, you know? And so I think that's what it is to be anti-racist. And that is a very intentional task.
Thank you. Thank you. You know, I'm trying to find the right word, insightful. Thank you for navigating this this important conversation with us. And, you know, as many of you, all three of you actually have asserted, this is not going to be solved with one conversation or by reading one book or by watching one documentary. It's a conversation that we need to have. And, you know, the words of the great late civil rights leader, John Lewis, comes to mind when he says, we may not have chosen the time, but the time has chosen us. It's been time. It is time now for us to act, to think, to reflect. So thank you again for this fantastic conversation. And thank you to our audience for fantastic questions. We're so sorry, sincerely sorry if we weren't able to get to all your questions. We will save them and we'll try to get back responses to them through emails or through an article or a blog at a later point. Also know that this webinar is recorded, and so it will be posted on the Creaky Joints website at www.creakyjoints.org. Also, if you're interested in continuing this discussion on Twitter, please check out #SpoonieChat, hosted by our dear friend and patient advocate, Dawn Gibson, tonight at 8 p.m. Eastern. Thank you very much again to our panelists for a very engaging discussion today. This webinar, again, will be posted on Creaky Joints within about 10 days. And if you're interested in joining us on other discussions like this one in the future, please consider joining Creaky Joints at creakyjoints.org, or our online community of patients, or Arthritis Power, which is our research registry for all patients living with rheumatic and musculoskeletal diseases. And if you haven't, we also encourage you to consider joining our free patient support program that we developed for all patients living with chronic disease, especially during this very challenging pandemic. So if you visit www.jhlf.org, you'll find more information about that. But with that, thank you everyone, and have a very pleasant evening. Thank you.